slide. So this is the results of the study. You can see with the demographics, really, I'll not dwell too much on all of this, but the three groups that we had, all of those, a total of 83 patients within the study. There was no difference in terms of the age and weight in these patients, and at the time of first consultation, they were all children essentially with complex heart problems. I suppose one of the most important findings was that we found that the actual addition of the video link was significant in terms of reducing the stress on the families. For them to be able to have visual contact was very important, and on this scale that measures the state anxiety index, that we find that there was a reduction in the STAI score, and that's obviously a very important finding. It was one of the aims of the study, and that's why we've brought this into clinical practice now. When we looked, it's a very important thing in all healthcare is cost, and when we did this trial, Brian McCrossan wrote this up. Brian did a lot of very good work on this study, and we looked at the costs to the NHS. Well, obviously, with babies with congenital heart disease, there's a low threshold to bring them to the GP or to the A&E department. And what we find that by making these links, that we could, on occasions, advise parents to deal with problems that they didn't need to come to the hospital. And in fact, financially, the implementing this program was a cost saving. That's one aspect of it. The other aspect is that whenever a child is unwell, we have had occasion where, thankfully, both Brian and Gareth, now Rosie, have picked up indications that the children were not doing so well and brought them to hospital, and that's been really beneficial in terms of getting them prompt treatment. So the odds of hospitalization, as you can see on the video conference group, were statistically lower than for the other groups, and that again just reinforces the benefits of this. I'll come, I suppose, towards the end of this presentation just to talk a little bit about how we can make that better still and how we might advance it in the future. The parents were very happy with this. Obviously, when we started out to do this work, we had intended that the monitors would stay in the home for a period of 6 weeks. What we have found is that when we get to the end of 6 weeks, nobody wants to give them up because they see it as a safe net, and we understand that, so we've been flexible around that. At the moment, we have the potential for 20 systems to be in the homes. We could, if we had the personnel and the resource, there are many others that we could give these devices to. And I should say, I suppose at this point, that this is something we see that's not just applicable to children with congenital heart disease. There are many children with other chronic conditions at home where we feel that this would in fact be a real boost to the service delivery to them in terms of care, and probably take the pressure off some of the visits to hospital for those patient groups. But that's something that we'll look to in the future. This is the healthcare costs, just to emphasize that in terms of the pounds per patient, we did see that there was a reduction in terms of what it cost. The green bar there on the video group is the actual cost of the telemedicine system. I don't have the exact cost to hand, but these small video conferencing systems cost in the region of £700–800 to put in, and as I say, we move them on to other families when they're done. So it's not an expensive program to run. So we have published a number of publications on this. We looked at what's the best methodology to do this, and we obviously have concluded that with the rollout of high bandwidth across the world, really, that the internet is feasible transmission modality.